ultrasound left elbow, pain and swelling 10 days post-injury. This seems a relatively straightforward request, but little did I know that this would be one of the best cases I've scanned in the past 12 months. This case demonstrates the utility and strength of ultrasound, has a number of key teaching points, and illustrates the importance of understanding normal so that we may recognize abnormal when we encounter it. The patient had an X-ray immediately before the ultrasound. We can see the anterior fat pad in front of and paralleling the distal humerus. That is, there is no Sale sign, there is no joint effusion, and the posterior fat pad is not detectable. On the AP X-ray, there's a faint density on the lateral epicondyle. It doesn't look like a typical fracture, but this will be an area we need to interrogate on the ultrasound. Now, the clinical skills and ability of sonographers are underestimated by essentially everyone. We get pretty good at seeing how someone moves and asking the pertinent questions that will allow us to formulate an idea as to what the likely diagnosis we'll encounter before the probe contacts the patient. And unlike any other profession, we get immediate feedback. So I asked the patient what happened. He explained that it occurred in a footy game. He was attempting to make a tackle and his left elbow became jammed between the ball carrier and a teammate. So immediately I thought to injuries such as these. We're looking here at a potential subluxation or dislocation event, and as such we're likely to encounter some significant pathology in essentially all quadrants of the elbow. Our starting point for pretty much all MSK studies is the joint assessment. Here is the coronoid recess, where we can see the anterior fat pad and a trace of normal physiological fluid. There is no effusion, which supports our finding from the X-ray. As we move laterally to the radial fossa, there is again no fluid. The radial neck appears normal, but we can see an edematous supinator muscle. The next point of assessment is the biceps insertion, and with ultrasound we can differentiate the heads of the distal biceps. A traumatic single-headed bicep injury typically affects the short head and would be a potential possibility in such a mechanism of injury, but in this instance the distal biceps insertion is intact, as is the brachialis, and what is not shown on these images is an intact and normal pronator teres and brachioradialis. From here I move laterally to assess the lateral collateral ligament complex, consisting of the radiocollateral ligament, annular ligament, and the lateral ulnar collateral ligament. This is a normal RCL that blends in with the annular ligament, whereas in our case we have a complete tear of the RCL and annular ligament. This echogenic focus towards the lateral epicondyle is likely the density we saw in the X-ray. I'll expand on this further in just a moment. This is a normal distal insertion of the lucal, whereas in our case we have a complete tear of the lucal. So now we've established that there is a complete lateral collateral ligament complex rupture, typically seen in a posterior elbow dislocation. This results in posterior lateral rotatory instability, or PLRI, of the elbow. Given the patient's age, such an injury is commonly managed by surgical reconstruction. If in doubt, we can simply compare to the contralateral side, where we can see a perfectly normal RCL and annular ligament. From here we slide the probe up ever so slightly to assess the common extensor tendon. Now we can differentiate the components of the common extensor tendon. This can help us be more precise in our diagnosis and management, especially of tennis elbow. I routinely scan from the mid-forearm towards the elbow in short axis. So here we can identify the EDC component and the tendon of ECRB. The ECRB component is typically implicated in tennis elbow or lateral epicondylitis. So it's important to know how to scan this in short and long axis. Back to our case, we can see marked edema and hematoma through the muscle belly of EDC, but the ECRB component remains intact and normal through to its origin. The remaining common extensor tendon, however, such as the EDC, EDM, and ECU component, are completely torn. As such, we have a full thickness, incomplete tear of the common extensor tendon. It looks something like this schematic. Again, if we're unsure, or even if we're looking to solidify our findings, we can simply compare to the contralateral side. Hyperemia is evident and not unexpected, and this image shows the extent of the muscle belly hematoma through EDC. So what is this echogenic focus? As we've said, it doesn't look like a typical fracture. Indeed, it's not a fracture. And herein lies one of the key takeaways from this case. Let us look at a similar but perhaps more familiar case in the shoulder post-trauma. Here we have a similar echogenic focus, and I'm sure we'd all agree that this is not a fracture. It's also not hydroxyapatite depositional disease or calcific tendinosis, and we wouldn't really expect this to show up on an x-ray. So what is it? Well, this is calcified fibrocartilage of the enthesis that has pulled away or evolved from the cortical bone. The enthesis is where a joint capsule, tendon, or ligament attaches to a bone. And this is the key point. If we understand the enthesis, what it's made of, how to identify it on ultrasound, then this unlocks the secret to so much musculoskeletal ultrasound, because so much pathology occurs at the enthesis. It consists of 4 parts: the collagen of the tendon or the ligament, the unossified fibrocartilage, which is this hypoechoic layer that's often mistaken as a tear, the calcified fibrocartilage, and finally the cortical bone. And with this knowledge, we can explain the echogenic focus on the lateral aspect of the epicondyle. This is calcified fibrocartilage of the enthesis of the common extensor tendon and radio-collateral ligament, which has pulled away from the underlying cortical bone. Medially, the common flexor tendon is intact, and the proximal MTJ of the common flexor tendon is also intact and normal. The medial collateral ligament complex consists of the anterior and posterior bundle of the ulnar collateral ligament, as well as a transverse component. The anterior UCL or Tommy John ligament is intact and normal. We can see its broad origin from the medial epicondyle all the way to its insertion on the sublime tubercle of the ulna. The posterior UCL usually sits along the floor of the retroepitrochlear groove, but in this case we can see no such ligament, suggesting a complete tear of the posterior UCL. Of note is an accessory muscle, the anconeus epitrochlearis, which has potentially protected the ulnar nerve from significant injury in such a posterior dislocation event. The triceps insertion is intact. We can see the medial triceps insertion and the long and lateral tendon insertion. Now, due to the nature of these findings and the potential for surgery, an MRI was performed. The only thing the MR demonstrated that the ultrasound and X-ray did not was a very small coronoid process fracture. Usually this would be accompanied with a joint effusion or hemarthrosis. I wonder whether this, having been performed 10 days after the injury, was enough time for that to have resolved. The MRI failed to show any calcific density in the lateral epicondyle, which is testament to the strength of ultrasound. I really enjoyed scanning this case. To be honest, I've been hanging out for an elbow dislocation for a long time now. I think this case shows the strength of ultrasound, and it also, above anything else, shows the importance of understanding normal so that we can easily and comfortably recognize abnormal when we encounter it. It also shows the value in understanding the once arcane concept of the enthesis, a concept that we have shown can be broken down and simplified, a concept that if we understand will categorically improve our MSK ultrasound. Thanks for watching, guys.